Hi, everyone. Thank you so much for being here today. It's August 16th, and we are in the Age-Friendly Geriatrics Tele-Echo series today. And today's topic is going to be focusing on dementia in detail, Lewy body dementia. Our agenda is just moving on into our introductions and our announcements, moving into the didactic, which will have some case discussions included, and then followed by our closing and our reminders. You all have been unmuted upon entry. So if you do have any questions, you're welcome to unmute yourself, introduce yourself, and ask our question at any time. And we will have room for questions at the end of the session. This session is accredited by Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians and other learners. Today's session is 1 hour and is available for 1 AMA PRA Category 1 credit for physicians. And you should claim only the credit commensurate with the extent of the participation in the activity. And of course, other boards are do accept reciprocity for CMEs as well. This project is supported by the Health Resources and Services Administration, and this information or content and conclusions are those of the author and should not be construed as the official position of HRSA HHS or the U.S. government. As we always do, we like to see where you all are joining us from. If you can please go ahead and place in the chat your name, your role, your site, and your location. It also helps us mark your attendance as well, so that we can make sure to get you your credits. While you do that, we'll go ahead and have our hub team introduce themselves. My name is Nika Seville, and I'm the project manager for our Geriatric Workforce Enhancement Program. And I work at the UCI Health Medical Center in Orange, California. And I'll go ahead and have PA Valerie George introduce herself.
Hi, I'm Valerie George. I'm a physician assistant and I work at Senior Health Center Geriatrics in our Orange office. Welcome today and I hope you enjoy the lecture. Thank you.
Thank you, Val and Dr. Sagel.
Everybody, I'm Sonia Sagel. I'm a clinical professor in the Department of Medicine and the Division of Geriatrics and Gerontology here at UCI. I too work at the Senior Health Center in Orange and also at one of our offsite locations in Laguna Hills. And I am looking forward to Dr. Pereira's talk on Lewy body dementia today. Welcome, everybody.
Thank you so much. And Dr. Pereira is one of our hub team members and she's going to be presenting, and I'll let her introduce herself as well.
Hi, everybody. Welcome. I'm Manisha Pereira, one of the geriatricians. I work at the Orange Senior Health Center as well. In addition, I do skilled nursing care as well. Welcome.
Thank you so much, Dr. Pereira. It looks like we have a really great group of learners on the line. Again, thank you so much for joining us. And I'll let Dr. Pereira take it away. And as you guys do this, I'll go ahead and probably put the links and things for your CME credits in the chat. So just look out for that. And I'll let Dr. Pereira take it away.
Thank you. Welcome, everybody, to this discussion on Lewy body dementia. Next slide. Today, I will be going over the introduction and epidemiology of Lewy body dementia and talk about the pathogenesis along with clinical features, the diagnosis, treatment, prognosis. I will also be discussing a patient I had seen in my clinic who was ultimately diagnosed with dementia of Lewy body. Next slide. So talking about dementia with Lewy body, I wanted to highlight that one of the core essential features of Lewy body dementia is a diagnosis of dementia. So I wanted to refresh a definition of what dementia is and kind of highlight on how dementia, Lewy body dementia fits into this big picture of dementia. So going back to our definition that we've talked about in the past couple of sessions, dementia is a clinical syndrome that's characterized by a decline in cognitive and function, cognitive symptoms and functional decline that's caused by a range of diseases and injuries to the brain. And when we talk about cognitive function, there are 6 main cognitive functions that we focused on, and that's memory, language, executive function, which essentially means goal-oriented task and planning, complex attention, perceptual motor function, and then social cognition. To diagnose dementia, we do need to see how it affects your function, either how you navigate yourself during the day with your daily activities or instrumental activities like managing your finances, driving, doing your laundry. And if the daily function is not affected, we call it a mild cognitive impairment. Next slide. So how does dementia, Lewy body dementia, kind of fit into this diagnosis of dementia as a whole? So we categorize dementias as neurodegenerative, non-neurodegenerative, and mixed type. And we have discussed Alzheimer's dementia as one of the is as the most common type of dementia. And then we talked about vascular dementia, which is a non-neurodegenerative, but it's the second most common type of dementia. Lewy body dementia is the third most common type of dementia, and it falls under neurodegenerative. Next slide. Lewy body dementia really is an umbrella term for 2 separate clinical entities. We talk about dementia with Lewy bodies and Parkinson's disease dementia. They both have similar clinical features, but we recognize them as 2 separate clinical diagnoses, mainly because the prognosis can be different, the progression can be different, and also sometimes the management can be different. And the main distinguishing factor is which symptom comes first. So in general, dementia with Lewy body presents with cognitive changes at the initial presentation, whereas in Parkinson's disease with dementia, you may have Parkinson's disease for a number of years before you have a diagnosis of cognitive decline. Next slide. Talking about dementia with Lewy body, so I mentioned that an essential feature is a degenerative dementia. We need to see a cognitive decline affecting their daily activities or social function or affecting their work. In addition, there are 4 core clinical features that we talk about when we diagnose dementia of Lewy body. You don't have to have all 4, but in general, you at least need 1 for a possible diagnosis, and for a probable diagnosis, you need 2. And these are visual hallucinations, symptoms of Parkinsonism, cognitive fluctuations, which I will go over what that looks like in a later slide, and REM sleep behavior disorders, like acting out dreams. Next slide. And in Parkinson's disease dementia, I mentioned that one of the main differentiating factors is the onset of cognitive decline. In general, to diagnose Parkinson's disease, we need to have a diagnosis of Parkinson's disease prior, at least 1 year prior to the cognitive decline. There isn't a clear reason as to why 1 year was chosen, but in general, as I mentioned, you need to have, most of these patients have a number of years of the diagnosis of Parkinson's disease before they develop dementia. in comparison to most dementias, Lewy body dementia is relatively under-recognized, and it may also be because of the clinical features and how it presents. And it also has a poor prognosis. It progresses rapidly, so it's really important to be familiar with the core clinical features and be able to guide these patients in the right direction. Next slide. So how common is dementia of Lewy body? Next slide. So it affects about 5% of our population. Currently, about 1 million to 1.4 million patients are already diagnosed with dementia of Lewy body. And that accounts to about 30% of all dementias. And the incidence is about 0.1% every year. A new diagnosis of dementia with Lewy body is made, which is about 3.2% of all newly diagnosed dementias. So really, if you look at the numbers, it may look like it's not very common, but it has already affected about 1.4 million patients who are living in the United States. But the diagnosis of Lewy body dementia or dementia of Lewy bodies is a difficult diagnosis because one, there are so many neuropsychiatric symptoms, there's rapid progression. So it's really important for us as the medical providers to be able to recognize and give them the support and the help they need. Next slide. What happens in Lewy body dementia? What's the pathology? Next slide. Sorry about this. I think the slides are not fitting in, but I will describe what this slide talks about. So in dementia of Lewy body, there are some similarities in pathology with Alzheimer's dementia and also Parkinson's disease dementia. If you look at the gross pathology, you will see cortical atrophy in dementia of Lewy body in the temporal, frontal, and parietal lobes, just like in Alzheimer's dementia. However, that atrophy is not as prominent or not as severe as in Alzheimer's disease. You may see more pronounced atrophy in the limbic structures in dementia of Lewy body. Similar to Parkinson's disease dementia, you will see some pallor in substantia nigra because it also affects the dopamine neurons. Microscopically, similar to Alzheimer's dementia, you may see the neurofibrillary degeneration and some of the proteins that we talk about in Alzheimer's dementia. But the pathological hallmark, Lewy body dementia, Lewy bodies are seen as similar to Parkinson's disease. Lewy bodies are folded alpha-synuclein proteins, and you see them in the nucleus of these neurons in the brain. In addition, you will also see this protein as an elongated beaded structure in nerve processes as well. There may also be superficial microvacuolation in the cerebral cortex in the microscopic pathology in Lewy body dementia. So as you can see in the pathology, there are some features similar to Parkinson's disease dementia, and then some features similar to Alzheimer's disease dementia. And this can also translate over to the clinical features as well, which I will go over in the later slides. Next slide. So this is an MRI of the first MRI is of a patient, a 61-year-old male who has been diagnosed with dementia of Lewy body. And then the second one is a patient, a 69-year-old diagnosed with Alzheimer's dementia. As you can see, there's more atrophy of the temporal lobes in the second MRI compared to the first MRI picture, which is of a patient with dementia of Lewy body. Next slide. And these are the Lewy bodies that was mentioned. As I mentioned, it's in the nuclei, and it's like a separate structure, which we call Lewy bodies, the pathological hallmark of dementia of Lewy body. But keep in mind, it's not specific to dementia of Lewy body. Next slide. So how does this form? It occurs in the alpha-synuclein proteins. These are found in the presynaptic terminals. It undergoes a structural change. So alpha-synuclein is in an unfolded form, and it folds to form these structures, which we call Lewy bodies. It is suspected that oxidative stress could be a reason. We don't know exactly why this happens, but it forms these structures and forms Lewy bodies and Lewy body neutrites. And it's not clear if these are neurotoxic or if this is an innocent bystander of the disease process. But we do see that cells, dopaminergic neurons are more susceptible as well. It's also noted that significant cholinergic neuronal loss and depletion of choline acetyltransferase levels in early dementia of Lewy body. And this has been associated with the presence of hallucinations in the initial presentation of dementia of Lewy body. So one may guess or suspect that there may be some role in acetylcholinesterase inhibitors in the management of these patients because of this pathology that we see. Next slide. So what causes the development of Lewy bodies and what predisposes us to developing dementia of Lewy body? It's sporadic, late onset. Age is the biggest risk factor, like most neurodegenerative dementias. About 5% of the diagnosed patients with Lewy body dementia has had genetic mutations implicated, but it's similar to other neurodegenerative diseases. There hasn't been one specific to dementia of Lewy body. And some of the examples are amyloid precursor gene, alpha-synuclein protein, which we also see in Parkinson's disease, and the ApoE4, which has been associated with Alzheimer's disease, is also can increase your risk of dementia with Lewy body. However, other acquired risk factors are also suspected. Some of the studies has shown a discordant incidence among monozygotic twins. So environmental factors are also suspected in predisposing us to this dementia of Lewy body. However, we need more studies to look into this. Next slide. So I want to now talk about my patient I saw in my clinic before I move on to the clinical features and diagnosis. So this is Mrs. P. She's a 74-year-old lady who comes into my clinic with her daughter to establish care. She's generally healthy. She has a diagnosis of osteoporosis and hyperlipidemia. The only surgery she's had is cataract surgery, and then no significant family history. She's now retired, but she worked at a nail salon. There's no history of alcohol or tobacco use. And the main concern for the daughter is her anxiety and the tremors that she noted about 1 year ago. Next slide. She's taking alendronate 70 milligrams weekly for the past 5 years for her osteoporosis, along with calcium and vitamin D, and she's also on pravastatin. The daughter reports that she's noticed her mom having worsening anxiety for the past year. She said she's always been an anxious person, but somehow since she got her dentures placed last year, she has become very self-conscious and she has difficulty using her dentures. And it has also led to like some weight loss because of that. She says that her anxiety has gotten so bad that she wakes up screaming from her sleep. She's also noted some twitching movements when the patient's asleep. She also mentions that the patient used to help the daughter with some activities, some tasks in the home, but now she gets so overwhelmed with simple tasks that she cannot complete them. And sometimes she even forgets to do them. However, she remains independent in her activities of daily living, and she takes her own medications and manages some of the finances. The daughter pays most of her bills. She doesn't drive. She never did. So I really couldn't assess if there was a decline in her baseline in driving. Next slide. And she also talks about tremors, which again started in the past year. The daughter has noticed this at rest and with activities. When I inquired, she said her handwriting has gotten smaller. And it has become really difficult for her to eat because whenever she tries to eat, she starts having tremor. The patient says that it's the tremor that's making her anxious. And however, the daughter thinks there's a lot more going on than just the tremor. Next slide. So on physical exam, she's not in acute distress. However, she doesn't really engage in the whole conversation I had with the daughter during her encounter, but she does answer questions when I ask. And her cardiovascular lung exam and abdominal exam was unremarkable. The neurological exam, no unilateral deficits, sensory system was intact. She did have a mild tremor in her jaw at rest. I did note some bradykinesia when she was doing a finger nose test, and her gait was stooped and with mild shuffling. Next slide. So in my initial evaluation, I considered an anxiety disorder that has, that has affected her daily function and may also affect her activities that she feels overwhelmed. So I considered anxiety disorder. I considered for the tremor, the Parkinson's disease was this essential tremor because she did have some tremor with intention as well. Lewy body dementia wasn't on top of my list, if I'm being perfectly honest. Hindsight is always 2020, but I just wanted to highlight that, in the initial presentation, this was what I was thinking about. I would like to kind of, highlight that this is how difficult it is to sometimes diagnose dementia of Lewy body. And you really have to pay attention to those specific core features as well. So my initial plan was do a basic laboratory evaluation, a comprehensive panel, B12, thyroid. And I did start the patient on escitalopram to help with the anxiety. And my plan was get her anxiety better controlled, and then maybe we can move on to cognitive testing because, mood disorders can affect your cognitive performance as well. Because of the tremor, I did refer her to neurology, but I did plan to follow her very closely because of her ongoing symptoms. Next slide. So now I want to talk about the clinical features and the diagnosis in detail, and then we could talk about the management and treatment as well. Because of the multiple clinical features of dementia of Lewy body, it has been helpful that the Dementia of Lewy Body Consortium has come up with specific clinical criteria to diagnose dementia of Lewy body. So I talked about the 4 clinical features. So if you have 2 or more, along with the cognitive decline, you can make a probable diagnosis of dementia of Lewy body. If you have 1 clinical feature, there are biomarkers, like tests that we can use to help our diagnosis. But if you only have 1 with no biomarkers, it's a possible diagnosis. And of course, you have to rule out other causes like physical illness and brain disorders as well. Yeah, next slide. So just to go over the cognitive decline, the dementia, which is an essential feature, again, we need to see how it affects their daily function. But I wanted to highlight here that as opposed to Alzheimer's disease, where memory is the most prominent and early cognitive deficit that we see, in dementia of Lewy body, we see a decline in attention, executive function, visuospatial function more prominently than memory. For example, there may be a history of patients getting lost with driving, failing to see stop signs, and maybe even getting into accidents, and more prominently than decline in memory. And if we do a cognitive test, we can also see if you do like the Montreal Cognitive Assessment, maybe they have more difficulty with doing the trails, the serial sevens, or clock drawing, or drawing the overlapping pentagon more than the memory functions that we test. Next slide. Sorry, Nika, is it possible to go out of presentation mode for this slide? And then can you share the screen? Sorry.
Are you trying to share the screen or do you want me?
I'll share my screen.
Okay, great.
Yeah. Okay. Can everybody see my screen?
We can. It's not in presentation mode, but it's okay.
Oh, you can. Okay, thank you. Sorry about that. I think this slide has a lot of more detail that I wanted to kind of talk about. So when I talk about cognitive function, okay, so talking about the core clinical features, I wanted to talk about cognitive function. In cognitive fluctuations, which is a core clinical feature, we do see fluctuations of cognition, like an extreme need to sleep during the day, disorganized speech and staring spells, which could last for several seconds to maybe several days in some situations. And sometimes it can be subtle as like inability to do your daily activities, or dramatic that makes the family members and the providers concerned about a TIA or even a seizure. This is considered more of a difficult core feature to kind of recognize, just because of the presentation, and maybe the family members may not connect it to the overall picture and may not mention it to you. So it's generally considered a more difficult core feature to recognize. Visual hallucinations, they are well formed and detailed. The patients may complain of seeing like children or small animals, or it could be visual illusions or misperceptions, like mistaking a tree for a person. And then we have the REM sleep disorder. where the typical story is that they're acting out their dreams. It may be something like they're throwing a ball during sleep. It can be a distressing symptom because it may lead to injuries in the patient or even their bed partners. The REM sleep disorder is considered a prodromal symptom, and at times it may occur about 6 to 10 years before clinical concerns for dementia of Lewy body. But keep in mind, it's not very specific to dementia of Lewy body. We can see this in Parkinson's disease, in brainstem lesions as well. And then we have Parkinsonism, which is considered a symptom that may occur later, but not always. And it can present with bradykinesia, rest tremor, rigidity, gait disorders. However, it can be mild, unlike in Parkinson's disease. In addition to the core features that I mentioned, there are some supportive clinical features that can help us with our diagnosis, although it doesn't fall under the main criteria to diagnose dementia of Lewy body. One of them is the severe sensitivity to antipsychotic agents, especially the first generation antipsychotics, but it can also be seen in the second generation like olanzapine as well. And then these can be sometimes very severe, like impaired consciousness, irreversible Parkinsonism, and even neuroleptic malignant syndrome. It has been stressed not to introduce these medications to patients as part of the diagnosis because it can be harmful. But of course, if there's such a history and there are other clinical features, it may help your diagnosis. Postural instability and recurrent falls are also seen in these patients. They may have syncope and transient episodes of unresponsiveness that could be attributed to orthostatic hypotension or sudden atonia and falls. That's not because of orthostatic hypotension, but because of dysautonomia that happens as well. And you can see how this could be a concern for a possible seizure when these patients have these presentations. And the dysautonomia is not limited to the orthostatic hypotension, but it could also present as urinary incontinence and constipation. And constipation is also considered a prodromal symptom. The patients may have a long history of constipation. But keep in mind, it's not a specific symptom. Not every patient who has constipation has the diagnosis of Lewy body, dementia of Lewy body. There may be a history of excessive sleeping. They may have difficulty with the smell. And then there may be hallucinations in other modalities, like having the sensation of insects on the skin, auditory hallucinations as well. Delusions are also a recognized symptom. And we talk about the Capgras syndrome, where they think familiar persons are actual imposters. And then there's a history of apathy, anxiety, and depression too in these patients. And I wanted to go over the biomarkers. In general, we don't do all of these tests. Sometimes these can be done in a research setting, but in a clinical setting, perhaps with the help of neurology, we may do a DAT scan, which may help support our diagnosis, or a sleep study if we can confirm the REM sleep disorder. The iodine myocardial scintigraphy, that's more to look at autonomic denervation, but I don't see that done in routine clinical practice. And I wanted to highlight some of the clinical features and differences between dementia of Lewy body, Parkinson's disease dementia, and Alzheimer's dementia. As I mentioned before, in dementia of Lewy body, prominently, we have a cognitive decline in executive function and visuospatial function, as opposed to memory in Alzheimer's dementia. And in Parkinson's, the cognitive decline occurs later. We see visual hallucinations as an early symptom of dementia of Lewy body, and in Parkinson's dementia, it usually occurs when we start medications that may cause these visual hallucinations, or later in the disease course. And in Parkinson's, in Alzheimer's disease as well, visual hallucinations occur later. The distinct fluctuations we see in dementia of Lewy body, that is a little, actually it's different to Alzheimer's dementia, where in Alzheimer's it's more of a vague changes that can present as good days and bad days for patients, whereas in the fluctuations we see in dementia of Lewy body, it could be abrupt changes and with near normal function in between these episodes. And Parkinsonism is a late presentation in dementia of Lewy body and an early presentation in Parkinson's disease dementia. Moving on to evaluation. So we always start with a good detailed history. Getting collateral history is really important, paying attention to the core features to diagnose these patients and the cognitive decline and how it affects their daily function. History of prior falls, sleep disorders, constipation, urinary incontinence is important, and also the past medical history, family history can be looked into as well, and pay attention to social history, because this really is a diagnosis where caregivers play a huge part, and we always need to pay attention to caregiver burden as well. In your physical exam, make sure to do an orthostatic, make sure to do your orthostatic vitals and the neurological exam as well. And you can do cognitive assessment, any cognitive screening test that you're comfortable with. And if there are subtle changes, you can always refer patients to neuropsychological testing as well. Basic labs like vitamin B12, thyroid can be done, and other testing can be considered depending on the presentation. You may want to consider consulting neurology also if it's not a clear presentation, and also for further management as well. So talking about Mrs. P, so on follow-up, she did have some partial improvement in her anxiety, but there wasn't a significant improvement. Between this time, we also had a consultation with neurology, and they did say that she may have a combination of Parkinsonism and essential tremor. And the DAT scan was done, which supported suspicion for Parkinsonian syndrome. A CT showed general cortical and subcortical volume loss. She was treated with carbidopa-levodopa, which helped control her tremors. And then later on follow-up, we had more clear-cut symptoms with the help of neurology, where we recognize the cognitive decline that affects her daily function, a history of acting out her dreams, and then also kind of not recognizing herself in the mirror, which caused a lot of anxiety, and the daughter had to actually close the mirrors to help her, kind of be comfortable in her own surrounding. So if you look at this presentation, we have cognitive decline, we have visual hallucinations, and then we have a history of acting out dreams, a sleep disorder, and then we also have the visual hallucinations and the DAT scan, and to support a diagnosis as well, and then the symptoms of Parkinsonism. So she had a MOCA, and here she did have a trouble with memory, but you could see that she had trouble with the attention, visuospatial, executive function as well. She had a sleep study, and it did confirm that she had the REM sleep behavior disorder. I want to talk about management next. So because of the symptoms, the neuropsychiatric symptoms of Lewy body, the caregiver burden, and the rapid progression of this disease, it's really important to have a multidisciplinary approach to these patients, which could include primary care, neurology, neuropsychiatry if needed, and social work, clinical pharmacology, and palliative care as well. Assessing for safety, like driving, having a discussion with them on stopping driving if they have a diagnosis of dementia is important. And here in California, we are mandated reporters. Look into a history of wandering behaviors if there's a risk of these patients getting lost, and consider medical alert bracelets as well. And again, early in the disease, if you have the opportunity, have discussions about long-term care planning as well. Unfortunately, there are no disease-modifying treatments available for dementia of Lewy body, and most of our treatment is focused on the symptoms and helping patients and caregivers control these symptoms. So if you look at cognition and behavioral symptoms, non-pharmacological approach is always important. And it always starts with educating caregivers about the diagnosis, about the symptoms, and how to manage these symptoms. You may want to get your social workers involved to help these patients find respite care, and encourage them to have a routine for the day, assess for pain or any other environmental triggers that could be distressing to the patient, and always pay attention to medication adverse effects. For cognitive and neuropsychiatric symptoms like visual hallucinations, we can use cholinesterase inhibitors. So there are 3 medications that we can choose from. Here in the United States, rivastigmine is the only FDA-approved medication for dementia of Lewy body. However, donepezil has been approved in the United Kingdom, and studies have not really shown that one is superior over the other. So it's, whatever that is suitable for your patient and that they can tolerate. But we need to monitor these patients for side effects like weight loss, worsening cognition as well. And there's no clear guidelines on the duration, but in general, you can use these medications for about 6 months to see if it has any benefit on the symptoms. For memantine, no clear data to show that it is helpful. However, I have seen it being used off-label. But pay attention if they are concurrently on amantadine, that it may increase the side effects of memantine. So pay attention to that. Antipsychotics, there is a role, but you have to use the lowest necessary dose and monitor closely for side effects and taper off, whenever you can taper off. So we have to avoid typical antipsychotics because they are very sensitive, and also avoid atypical antipsychotics like olanzapine and risperidone. There has been some use on quetiapine and clozapine in low doses if none of the other measures help these patients. Pimavanserin has been approved for Parkinson's disease psychosis, but not for dementia of Lewy body. Again, if used, it's off-label. SSRI and SNRI can be used. You need to monitor for exacerbation of REM sleep behavior disorder while on these medications. Avoid benzodiazepines because of its adverse effects. The only exception is clonazepam, which can be used in REM sleep behavior disorder, but not for cognitive or neuropsychiatric symptoms. For the REM sleep behavior disorder, we can try melatonin as first step. However, you need to look into any exacerbating factors, like are you using an SSRI for depression symptoms? Is that exacerbating her sleep disorder? And acetylcholinesterase, like donepezil, can be used as well. And as I mentioned before, the clonazepam in low doses if the other measures do not work. And for Parkinsonism, we can try carbidopa-levodopa. It's recommended to use a small dose and titrate slowly and monitor for exacerbation of psychotic symptoms or orthostatic hypotension. For orthostatic hypotension, non-pharmacological measures like making sure they stay well hydrated, have normal salt intake, raise the head end of the bed, and then standing up slowly using compression stockings can be used. If that doesn't help, you may look into medications like fludrocortisone and midodrine, but we need to monitor for supine hypertension if they're on these medications. Urinary symptoms are generally recommended to avoid antimuscarinic agents because it can worsen the cognitive function. We can consider beta-3 adrenoceptor agonists like mebetriq to help these patients with the symptoms. So survival is generally considered shorter than in Alzheimer's disease. The mean average years is about 6.1, as opposed to about 12 in Alzheimer's disease. Certain factors like prominent cognitive fluctuations, early hallucinations, gait abnormality, psychiatric symptoms requiring antipsychotics, orthostatic hypertension, and prominent hippocampal atrophy on MRI are considered kind of factors to suggest a poorer prognosis in general. And moving on to Mrs. P, she was started on levodopa and carbidopa-levodopa for her tremors, which did help her. Melatonin was started for her sleep, REM sleep disorder. We tried Aricept, donepezil, and we increased the dose. However, she didn't tolerate the medication, so we had to stop the medication. Briefly, we tried memantine, but again, we stopped memantine because of lack of improvement. She is now on pimavanserin, and it's used off-label, but it's with the guidance of a neurologist that we're using pimavanserin. And then we also referred her to psychiatry because escitalopram was changed to citalopram, and then now she's on sertraline to help with the anxiety symptoms. And our social worker is also in touch with the patient, and we have referred her to adult daycare as well. So that's the end of the presentation.
Thank you, Dr. Pereira. Looks like we might have some time for questions. It looks like we do have one in the chat. Leslie Law says, with urinary symptoms, have you ever tried desmopressin spray when mirabegron doesn't work?
I haven't personally tried desmopressin spray. It can be tried, but in my experience, we have to pay very close attention to hyponatremia. If you're using desmopressin.
Thank you, Dr. Pereira. Any other questions on the line? We can stay on for a few minutes. If anybody has any questions, you can put them in the chat or you can unmute yourself. While I wait for you all to do that, I will let you know that if you do want CME credits, please go ahead and scan this QR code and fill out the quick questions that are available on the survey. And then we always do appreciate your evaluations as well. We do have a few upcoming sessions. We're taking a week break because of Labor Day, but we do have on September 6th, emerging treatments for dementia, followed by brain health, prevention of cognitive impairment. And then on August, sorry, that one's the wrong date, September 20th, should say geriatric emergency medicine. So we hope you can join us on those sessions. And just a reminder, every week our link, our Zoom link is the same exact link. So if you don't have the calendar invite or anything, you can always just join using the